the organizers and Dr. Rabbani and team for giving me this opportunity. So if you look at the intervention, definitely the bifurcation is considered to be one of the difficult subset, and more often than not, one of the complications on table would be because the side branch got occluded. So a coronary bifurcation lesion at or near a division of major coronary arteries, and we have seen, from data that there are many classifications has come up, but the simplest and most practical of the lot is the Medina, where where the plaque is maximum and where the plaque distribution is, that is the prime determinant of outcome. So the simplest and most widely used is the Medina classification, and we give one score to each, and this is how we, Mercedes-Benz classification kind of sign, which is 1, 1, 1, and then it could be varying from, to right up to 0, 0, 1. So based on this, we take out a strategy where and how to proceed. So we always say that when we have to do a intervention, we need to really do a procedure planning, because as it has been said that if you are not planning, if you fail to plan, you are planning to fail. So similarly, if you haven't have a strategy, it means that disaster would happen on table. So basically what we do is that the mother of all bifurcation is the distal left main bifurcation, and that's the problem where we need to focus maximally. So we say that if the, there also, if the patient has significant, both the branches are significantly involved, then we need to have a good heart-aim decision, or the interventional cardiologist should always face that is the lesion suitable for intervention. If it is not, then still for distal left main, the CABG is a better option. So for complex bifurcation and trifurcation, and if all the branches are of bigger size, then the surgical intervention would be a good choice. So when we assess an bifurcation, we should always look at the anatomy of what are the diameters of the vessels, where the lesion distribution and plaque distribution is there, and the bifurcation angle is also very important, and side branch ostium. So the principle is that the mechanism may lead to compromise or flow in the ostial side branch, plaque shift may be there, carina shift, and ellipse deformation of the ostia may be there. There may be predictors of compromised coronary flow in side branch after left main to LED crossover stenting. So we need to look at the stent length. We also have to have adequate size for the pot in the proximal part, and then the plaque burden in the side branch is also very important. And imaging is a very important tool, especially if the larger branches and complex bifurcation we are doing. We need to image so that the data is quite clear, whether we are doing optical coherence tomography or the IVUS, it gives a good idea. So when we doing the left main bifurcation, the formula of 5, 6, 7, 8, which is the effective IVUS stent area, which shows that in long term the complications and adverse outcomes would be lesser. So this is what we need to achieve for. So when we do imaging as a pre-procedure, so like this is a case where the LED diagonal bifurcation, so we need to assess where the anatomical assessment is there, mechanism of side branch stenosis, we need to find it out, and then longitudinal view analysis is very important when we are imaging bifurcation, so that the longitudinal view is important to predict what will happen to the side branch after main vessel stent implantation is there, to locate and measure the length of the carina and understand the geometry of the bifurcation lesion also, because this shows that how little plaque is there in the side branch ostium. So based on that, we can plan a strategy, and believe you me that all the strategy of two stent technology and all has come, but the best is yet a single crossover stent technology. So we need to focus on that. So the imaging gives us a stent landing zone and reference analysis. So we always go by the distal vessel reference diameter. The morphology of plaque at the bifurcation is important. So if plaque burden is not much, more often than not, we need to not touch that. Measurement of the length, lesion length also is important. So in bifurcation area, even with this single stent strategy, if you have not covered the whole plaque, the risk of edge restenosis and all is very high. So we need to be really careful about that. And angiographically silent disease is very important to find out, and you cannot find it out unless you have done imaging. So that is why the imaging is very important. Also, we need to look at the post-procedure IVUS assessment of the bifurcation lesion. So this is the under-expansion and over-expansion of the stent. So sometimes, if this is the optimal stenting when you do post-stent analysis, but when you try to do, a pot at a too far distal, then there's an overexpansion of the side branch, and then you can see the carina shift is there. So this is not desirable. So that is why the proper technology and the imaging is important in these. There are various techniques that whenever the bifurcation is there, we must always, even if it looks simplest of the bifurcation, we should try to wire both the branches before, and then the European Bifurcation Club has always harped on that we should focus on single crossover stent technology, and the provisional should be the name of the game. So we need to always do a side branch stenting, and in main branch pot is important, and after that we need to think about the second stent is required or not. There are various data which shows that even if the side branch looks pinched, but if the FFR is okay, then we don't really need to do a side branch stenting. So provisional stenting approach, as we have already discussed, that pot is very, very important aspect of that, and we don't really need to finish with side branch kissing balloon in provisional stenting. Pot is good enough, and you can clearly see how optimally it opens up the struts into the side branch, and that is why the single stent strategy with pot is the base thing. There is a, in Oriental countries, there are a lot of this new technology is gaining momentum, where what they do is that gel balloon technique. So this is how a gel balloon technique is there, that the uninflated balloon is kept into the side branch and you stent it, and the chances of occlusion of the side branch, even if the plaque is there, is significantly lesser, but it's not very commonly practiced by purists. Then the two-stent technology, Culotte technique, has been in use, but of late, once the decay crush has come, especially for the left band, this is less commonly used. But here again, it's a compelling two-stent technology. So steps are here that you first go into the side branch, stent, and then rewire, and then re-stent, and then only thing is that in the proximal segment, the metal load is significantly high, but you need to do a kissing, and then you can end up with double balloon kissing technique. So mini crush technique, again, it's a simpler than the decay crush technique, where more often in LED diagonal or circumflex OM branches, or even in distal RCA, PDA, PLV, we prefer to do a mini crush where the couple of steps are preserved, and here again the whole carina is covered with these stents, so that the risk of restenosis is lesser. In decay crush, you need to do twice, kissing, and twice, once before the stent and one after the stent. But definitely the metal load is high, but the data has clearly shown that this technique where the risk of restenosis in distal left main bifurcation is significantly lesser. So it's superior than the recent data again from European Bifurcation Club, where the cross of two stent technology other than the decay crush did not find out to be superior than the decay crush technique. So a couple of cases I would show. This is a patient who was 76-year-old gentleman who had a previously stent in the osteoproximal segment of circumflex. After 5 years, he came with restenosis and also involvement of LAD. So in this case, as I said, we need to do a double wiring, and then we need to do imaging to find out what is happening to the ostia, and the intravascular imaging or OCT would give us a very real clue that up to which class the plaque distribution is, size of the vessel, proximal and the distal as well. So we again, in this case, we did a dilatation of both these things. Since there was already a stent into the proximal circumflex, so left main to circumflex was stented, and then it was again recrossed, and then LAD was stented, and then the T-stent technology was done, and then after kissing balloon, pot was again done, and then it ended up with the imaging. So imaging showed perfect apposition and good outcome, and you can see that the post-stenting IVUS evolution. So in these cases where you have really optimized the things well with imaging, you can clearly see that the post result looks fantastic compared to the pre-result, and in these situations the long-term outcomes will also be better. This is a patient where it looks like that it would be just the ostium and the shaft of left main involved, but we did did in imaging and found out. So this patient was advised 1 year back, 1.5 years back, it was felt that probably the lesion is not significant and was advised FFR. Then during the COVID, this third wave, he came and he had significant symptoms. So FFR was also done just to find out what is the significance of the lesion. And both imaging and physiology was done in this case. And imaging did not show significant lesion in the ostium of the circumflex. So this is a case where, we thought that we will do. So initially, on angiographic view, one could have just finished the stent into the left main, not going to the LAD, but there was significant plaque in the LAD, which was angiographically silent. So we did a crossover stenting, and again, POT did, and single stent strategy did the trick in this case, and the outcome was really good. So I think in this situation, the imaging would really be the answer. So again, the last case, the patient had, left main LAD disease. You can see that there was a lesion in the circumflex also. So it was, again, imaging was done. So left main, which looked not significant, was having moderate plaque and would have come back with the restenosis. So again, we did dilatation and crossover stenting. And the imaging did really give us information that the left main is almost 5 millimeters, so almost 5.1. So we had to dilate with 5 millimeter balloon. So, in initial without imaging days, we used to do with 4 millimeter and be done with that. But after the, imaging, you can see that the optimization of the left main with proper size balloon is done. So take-home message, friends, is that provisional approach, one stent technique is recommended approach in non-complex bifurcation technologies. DK crush or nano crush, all these technologies are gaining momentum. POT is a crucial technique during any left main or bifurcation strategy, and final kissing balloon are optional for provisional stenting, but for mandatory for any two-stent bifurcation technique to reduce complication. Thank you very much for your kind attention.
Yeah. Thank you, Dr. Viveka, for such a wonderful presentation. Remember that the lesion in the side branch should be within 3 millimeter.
Yeah, that's good.
So, because the main vessel stent can cover up till 3 mm.
Yeah.
So, one must remember this thing, that if disease is extending beyond 3 millimeter, then you have to go for a 2-stent.
Yeah. So, and some of them say that up to 5 millimeter
yeah,
is
but
also.
I think, as of my experience, I think 3 millimeter, it cannot go beyond 3 millimeter.
Yeah, that's very good piece of advice, yes.
Yeah. And my question to you is that how you do this POT in provisional to avoid this final kissing balloon? Because the standard practice is to do a final kissing balloon dilatation. So how can you do POT to avoid this final kissing balloon?
So you need to, when you are doing so in this situation, the stent boost is sometimes very useful, and you need to sometimes recross the side branch to get a landmark for the side branch, and you need to go up to the proximal strut, which is hugging on the proximal wall of the side branch. So up to that place, your balloon has to be there. So that is why the balloon with less overhang is very important in these situations. So the place where the balloon marker is there, it's like an abrupt end of the balloon, so they don't encroach into the beyond the carina. So they don't distort the carina, and that is the correct way. So you should not miss the side branch proximal segment when you are doing a POT. And POT, what it does is that it opens up the cells towards the because that's the place where the stent will expand inside branch, because there is no other space. So that is how the stent keeps the struts, they open up, and by opening up slightly bigger diameter, they naturally, the strut, between the two struts, the space also becomes more in the direction of the side branch. So that is why, you don't really mandatory do, kissing balloon in that situation. And it has been seen that, though the data is very scarce, that when you do compulsory, kissing balloon, especially if you have got side branch lesion, moderate or mild plaque up to 3 to 5 millimeter, then you will induce a restenosis in side branch. And many times we have seen that after 4 or 5 years, patients have come back with the purely side branch restenosis, and you can easily cross the stent. If you have done the POT, you can cross through the stent and do, treatment of the side branch after many years of that also.
Yeah. So your POT balloon should be on the main vessel wire or on the side vessel wire?
No, so it should be on the main vessel wire ideally, but there is
so then it cannot be opening the full strut in the side branch.
No, so that's what I'm saying, that on the main vessel also, if you dilate it, then because it becomes a tapering kind of thing. And when it tapers, the funnel of the stent gives a diameter towards the side branch also. So it automatically opens up. I have shown one of the diagrams.
So this is your standard practice?
Yes, that's the
Any comment?
Yes,
from
for the interruption.
of late we are doing more of decay crush and mini crush, but there may be a few subsets of patients where we go for culotte, because in left main, the coverage of the crania is best with the culotte technique. So your experience with that?
Yeah, so I think it's always the techniques are there, but I think the golden rule in intervention is that you should be doing what you are comfortable doing with, because so if you are familiar and you are happy with culotte technique, there is no harm in going ahead with the culotte technique, but it's the operator's preference also. The decay crush is something which is less or demanding, I would say, because the risk of in the operator's mind is always there that the side branch may get occluded. So you always go with the technique which you are more comfortable with. But I think on a given day, both techniques are equally good. There is hardly huge difference between the outcomes.
Yeah. I'm sorry for the
Any
interruption.
comments from expert panel?
Thank you, sir. It was fantastic and lucid as always, your lectures. So, what is your opinion regarding a lot of people, including me, are doing a mini culotte technique, in which we keep minimum struts, maybe one single strut or two struts in the left main, and then proceeding. So what is your opinion regarding that?
So I think that's what we are moving towards, because the standard culotte has got too much of metal load. So mini culotte, or even that, for the crush technique, mini crush techniques are getting more, acceptance than the standard one.
Okay, I'm sorry for the interruption, Mr. Chairman. We have totally run out of Kata, West Bengal. Dr. Hazra, please.
Morning, Lucknow. Friends, today's talk